The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hello and welcome to Modernizing Your Radiation Oncology Practice with Tumor Treating Fields and other novel multimodal strategies. Today we're going to talk about the understanding the science of tumor treating fields, the evidence behind tumor treating fields, and we'll get into some of the practical aspects across a range of solid tumors. I'm Dr. Matthew Ballo from the West Cancer Center and Research Institute, and I'm joined by my colleagues, Dr. Hani Babakar from the University of Arizona and Dr. Rupesh Kotecha from Miami Cancer Institute.
Well, thank you. It's great to be here.
Thank you very much, Dr. Ballo. It's an absolute pleasure to be here.
So in this activity, we're going to be reviewing the cutting-edge advancements on the use of tumor treating fields in solid tumors. We'll be providing you some of our insights on this innovative and emerging strategy. And I think that you'll find that this will really enhance your radiation oncology practice. So we're going to start by talking about the biology and physics of tumor treating fields. So tumor treating fields have been around now for more than 2 decades. Starting in 2004 is when we start to collect clinical data. And you have EF07, which was the pilot trial in patients with glioblastoma. Fast forward to 2011, and you have FDA approval of tumor treating fields in patients with recurrent glioblastoma. 2015, FDA approval in patients with newly diagnosed GBM. And then you have FDA approval in 2019, just recently, in patients with unresectable malignant pleural mesothelioma. So we're going to go over these results, and then we're also going to talk about ongoing trials in solid tumors. So tumor treating fields are antimitotic therapy. They're antimitotic just like radiation therapy. They're antimitotic just like systemic chemotherapy. Of course, the mechanism of action is very different, but they are antimitotic. And why is that? Because cells are made up of large polar molecules that can be influenced by the presence of an electric field. So during metaphase and anaphase, when you have large molecules like tubulin or septin that need to align in a very specific orientation, they can't align in the presence of an electric field. And during telophase, when you have the formation of a cleavage furrow, you have a high intensity electric field where the DNA particles are drawn towards the cleavage furrow rather than separating into the daughter cells, causing mitotic catastrophe. So that's a brief summary, and this video will go into some more detail of the mechanism of action.
In metaphase of cell division, cells are a rounded shape as the mitotic spindle forms. Intracellular components such as macromolecules and organelles are naturally charged. Tumor treating fields, or TTFields, disrupt cancer cell division by physically interacting with molecules required for mitosis. When alternating electric fields are applied to cancer cells, they disrupt microtubule polymerization. Tubulin dimers align with the electric field and are not able to form microtubules. This prevents the organized assembly of the mitotic spindle required for normal cell division. The inhibition of microtubule formation leads to metaphase arrest and cancer cell death. In addition, these deformed microtubules can lead to abnormal DNA segregation between daughter cells, which also results in cancer cell death. TTFields can also affect cells after metaphase. If a cancer cell has passed metaphase and enters the cytokinesis phase, the cell takes on an hourglass shape. This state under TTFields creates a non-uniform electric field inside the cell, creating dielectrophoresis. Net forces push the macromolecules and organelles toward the mitotic furrow, and this disruption leads to structural disorganization and cancer cell death.
So there are three dependencies that are really important to remember. The first and most important is frequency dependency. Individual cells are sensitive to a very specific frequency of tumor treating fields. And the optimal frequency is inversely proportional to cell size, such that smaller cells are inhibited by higher frequencies, and larger cells are inhibited by lower frequencies. The second important dependency is an intensity dependency, where it seems like 1 volt per centimeter is a threshold where you see increasing inhibition of cell growth. If you apply tumor treating fields to multiple cancer cell lines, to the frequency of that it is most sensitive to, you'll see that above 1 volt per centimeter, you start to see significant inhibition of this cell growth. So that's an important dependency. The third dependency is a time-dependent effect, where the longer cells are exposed to tumor treating fields, and you can see here different cell lines exposed to 24 hours, 48 hours, 72 hours, and so on, you see significant inhibition of cell growth the longer cells are exposed to tumor treating fields. We also see synergistic effects. In 2 different cell lines, you can see that tumor treating fields alone, temozolomide alone, or combinations of temozolomide and tumor treating field leads to an additive or a synergistic inhibition of cell growth. And this will be important when we look at the data in patients with glioblastoma. When you combine cisplatin with tumor treating fields or pemetrexed with tumor treating fields, you also see this synergistic or additive effect and increasing inhibition of cell growth. And this, of course, will be important when we look at the clinical data for patients with mesothelioma. So what about visualizing the spatial distribution of tumor treating fields? This is something that's not exactly easy to do, but it can be done using computer modeling. What we do is we create a 3-dimensional reconstruction of the head and the brain, and you segment individual tissues. So you segment the scalp, the skull, the gray matter, the white matter, the CSF, and then you place the arrays on this 3-dimensional reconstruction of the scalp, and you apply electric field parameters to those arrays. And then you apply the dielectric properties or the conductivity to the individual tissues. And you're solving Maxwell's equation across the interface of these meshes. So you're propagating an electric field across the interface of these different tissues, and you get a 3-dimensional field distribution. And so here you can see the field intensity through the brain. On the left, you see a symmetric placement of the arrays and a symmetric distribution of the tumor treating fields, but you can manipulate the field intensity by moving the arrays so that you can significantly increase the delivery of tumor treating fields and the intensity of tumor treating fields to regions of brain. Now, you cannot focus the same way that we can focus a radiation therapy beam, because remember that tumor treating fields are measured in kilometers rather than the size of a small molecule. So that's some of the basic science, the biology and the physics behind tumor treating fields. Today, we're going to hopefully enhance your radiation oncology practice by improving your awareness, but also talking about your ability to integrate novel modalities such as tumor treating fields into solid tumors. We're going to start by reviewing the data in glioblastoma, and then Dr. Kotecha will overview tumor treating field therapy in thoracic malignancies, including mesothelioma and lung cancer. And then Dr. Baberger will provide us with some insight into the future of tumor treating fields regarding the management of a multitude of other solid tumors. Along the way, we're going to include practicum sections looking at specific patient cases and examples. We'll talk about clinical implications of tumor treating fields therapy for our patients. And then please make sure to enter your questions in the space provided, and we'll be answering them throughout the presentation. So the first seminar, and Practicum 1, is going to be reviewing the latest evidence of tumor treating fields for glioblastoma. Now, as you all know, glioblastoma is the most prevalent and aggressive central nervous system cancer in adults. Disease is historically very poor because of a limited number of treatment options. And disease prognosis depends upon age, the extent of surgical resection, tumor location, genetics, and functional status. Now, how are tumor treating fields delivered for patients with glioblastoma? This is a portable, non-invasive device. Patients are actually shaving their scalp and they're wearing the arrays on their shaved scalp and plugging the arrays into a lithium battery, and this is delivering a low-intensity, intermediate frequency, alternating electric field. These are single-use transducers that patients are replacing every 2 to 3 days. And of course, remember that the position of the transducers are individualized for every patient to maximize the field intensity through the region containing their tumor. And that's performed using an FDA-approved software where you are entering the morphologic head size, you're entering the tumor location into the software, and then the software tells you the best placement for the arrays to maximize that intensity. And that's exactly what was done in the EF14 trial. So the EF14 trial enrolled patients who had already completed their concomitant temozolomide and radiation therapy for newly diagnosed glioblastoma. All of the patients had undergone maximal surgical debulking of their tumors, and they were randomized in a 2-to-1 fashion to either tumor treating fields 18 hours a day until second progression, along with their temozolomide chemotherapy, or they were randomized to adjuvant temozolomide alone. This was a very large study, well-performed study. Patients were appropriately stratified by their resection status and by their MGMT methylation status. And you can see that there was a clear improvement in overall survival. Those patients that used the tumor treating fields and temozolomide had a median survival of 24.5 months, and those patients randomized to the temozolomide alone had a median survival of 19.8 months. So clear improvement in overall survival. And some had said, well, maybe patients who had undergone biopsy, would not benefit, or patients of elderly age maybe would not benefit. But no, just the opposite was true. In the subgroup analysis of EF14, all subgroups benefited from the use of tumor treating fields. This is a forest plot from EF14. And regardless of methylation status, resection status, age, performance status, all patients benefited from the use of tumor treating fields. Another comment was that by using tumor treating fields, maybe my patient won't be able to function and perform activities with their family, or they may not be able to go out to a restaurant. But again, the investigators of EF14 looked at the quality of life using the EORTC QLQ-C30 questionnaire and showed that there really was no difference in cognitive functioning, emotional functioning, physical functioning, and importantly, that role functioning and social functioning. There were no differences between the treatment arms. Now, if you remember back to the basic science, the laboratory data that I referred to earlier, I showed that the duration of time that cells were exposed to tumor treating fields was important and led to significant inhibition of cell growth. Well, we saw the same thing in the clinical trial, where the longer patients wore the device. Remember, everyone was supposed to use the device 75% of the time, which is 18 hours a day. But some patients used it more and some patients used it less. And there was a stepwise improvement in overall survival the longer patients wore the device. Really, almost perfect translation from the laboratory. And this was independent of their performance status or their resection status. We also looked at intensity in these patients. Again, remember from the laboratory that there was a threshold of about 1 volt per centimeter that seemed important. Well, when we looked at that same threshold in the patients on the EF14 trial, patients who had an intensity of the electric field greater than 1 volt per centimeter had longer survival than those that had an intensity less than 1 volt per centimeter. And this was independent from compliance. So it's important to note that it's not just the amount of time you wear it, and it's not just the higher intensity, but both together can be manipulated. We wanted to take this research one step further, and we actually segmented the individual volumes because the study that I just mentioned was performed looking at intensity through an entire region of brain. But we wanted to look at individual tissues within the tumor bed. So we segmented the gross tumor volume, we segmented the resection cavity, and a zone around that on the baseline MRI scans. And then on patients' progression MRI scans, we segmented tumor that stayed normal, tumor that regressed to normal, normal tumor that stayed normal, tumor that progressed to more tumor, and we contoured normal brain that progressed to tumor. And we looked at the intensity of the electric field through these different subsections of tumor bed. And we saw that consistently the average dose density in areas of tumor that regressed to normal was higher, 0.83, than the areas of normal brain that progressed to tumor, where the intensity was lower, 0.71. And this was statistically significant, and we saw it consistently across the different tissues that we looked at. So an important finding that Tumor Treating Fields is changing the pattern of failure in patients with glioblastoma. So a couple of questions flashed up on my screen from the audience. And one in particular was, can you comment on the selectivity of Tumor Treating Fields on normal tissue? And this question makes me think back to the basic science that I showed, that there is selectivity, that you have a situation where smaller cells are sensitive to a high frequency, and the larger cells are sensitive to a lower frequency. So there is some ability to target the cancerous cells and spare the normal tissues. There was another question about, do you see any toxicities? And really, I'll speak specifically to the glioblastoma results. The one toxicity that we saw in EF14 was some minor irritation of the skin. And I think we can talk later about managing that. So practicum 1, this is a case of a glioblastoma patient. This was a patient of mine, a 61-year-old woman. She described a few weeks of word-finding difficulty, persistent left eye pain, and visual abnormalities. She had a good performance status otherwise. She underwent an MRI scan of the brain in May of 2016 that showed an intracranial mass, and then underwent a MRI scan confirmed gross total resection, and the pathology confirmed glioblastoma. She was treated with temozolomide and radiation therapy. She started her tumor treating field therapy in October of 2016, and it seemed like during her use of the adjuvant temozolomide, she really used the tumor treating field well, staying above the 75% threshold. After completing her temozolomide, her compliance or usage of tumor treating fields fell off, and maybe related, maybe unrelated, developed a periventricular recurrence in October of 2017. She received second-line temozolomide chemotherapy, and really we encouraged her to continue her tumor treating fields therapy, and she has continued to use tumor treating fields through July of 2020. She has remained alive with disease after a recent radiosurgery for a small local recurrence. She has unfortunately had a declining performance status. She has experienced some depression after the death of a grandson, and she has had a couple of erosions with one prominent lesion on the vertex of her scalp. So what I thought was interesting about this case was, declining performance status is sometimes hard to address. Obviously, her depression is an acute depression after the death of her grandson. We can help her overcome that. But for today's talk, really focusing in on the management of their skin toxicity, because you want to try to remove and avoid as many hurdles as you possibly can. I thought it was important to talk a little bit about the management of dermatologic events. So I'll just kind of throw out there to Dr. Kotecha or Dr. Babaker, have you had experience, and what have been sort of your experiences taking care of these minor skin irritations that occur during tumor treating field therapy?
So that's a great question. For a majority of the patients with glioblastoma, as well as malignant pleural mesothelioma, which I'll actually discuss in my section, the majority of skin irritation or dermatological adverse events are mild to moderate, and most patients are actually managed with adequate counseling, use of topical corticosteroid solutions and creams, as well as providing lotion, and counseling about how often they may need to change the transducer arrays.
Yes, one of the other things I've noticed is that the worst part of the reaction seems to be right underneath the contact, and that if you can move obviously it's very hard to remove the entire array, but if you can just move the array 1 centimeter, one direction or another, that seems to help with some of the worst part of the dermatitis. Okay. Next question is going to be, or the next section is going to be a seminar and practicum on integrating the state-of-art multimodal strategies for mesothelioma and other lung cancers. And this is Dr. Kotecha.
Well, thank you, Dr. Ballo. In this second section, we're going to pick up off of glioblastoma and move to integrating state-of-the-art multimodal strategies for mesothelioma and other lung cancers. So mesothelioma is a rare malignancy, and only 3,000 people a year are diagnosed with this in the United States, but it does account for 2,700 deaths. Now, most people with mesothelioma are men and are diagnosed when they're 65 years of age or older. There is a strong link with previous history of asbestos exposure, and that's typically due to occupational exposure. With regards to mesothelioma subtypes, malignant pleural mesothelioma is the most common and accounts for about 60 to 70% of cases. Now, there's no consensus on the optimal treatment of malignant pleural mesothelioma, given this is a very rare malignancy. And basically, patients are identified and put into 2 buckets. The first is for those patients who have disease that is limited to 1 hemithorax, limited or no nodal metastases, a good performance status, they're able to undergo a gross macroscopic resection, and they have a favorable histology, epithelial histology. Those patients may be candidates for extended pleurectomy and decortication, and less frequently extrapleural pneumonectomy. These patients also receive neoadjuvant or adjuvant chemotherapy, and radiation therapy is currently being tested in this setting. This only works for about 20% of patients who are candidates for this type of approach. Therefore, for the majority of patients who are not candidates for this extensive surgery, they are treated with chemotherapy, which is typically a pemetrexed-based regimen with cisplatin or carboplatin. And there's also consideration for the addition of bevacizumab. It's important to note that there are no standard of treatment second-line setting therapies. And most recently, in 2019, we have the approval of Tumor Treating Fields in combination with pemetrexed and platinum-based chemotherapy as a humanitarian device exemption. And now we also have another treatment option, the introduction of immunotherapy into this space as well. It's important to note that whenever available, clinical trials should be considered for these patients. Now, there are 2 important landmark trials to consider with regards to the systemic therapy management of malignant pleural mesothelioma. The first on the left here is a trial in which patients were randomized to cisplatin or cisplatin and pemetrexed, which demonstrated an improvement in overall survival from 9.3 months to 12.1 months with this doublet regimen. A subsequent trial tested this regimen against a triplet regimen with the inclusion of bevacizumab that also improved the overall survival from 16.1 months to 18.8 months. Still, there are limited treatment options for this patient population, and even with doublet or triplet regimens, the chemotherapy response rates are lower than what we see with other thoracic malignancies. And therefore, given some of the preclinical evidence that Dr. Ballo mentioned in the first section about the combination of Tumor Treating Fields and these chemotherapy regimens, platinum-based therapy, as well as pemetrexed, there is a potential role for Tumor Treating Fields in this patient population as well. Now, Dr. Ballo mentioned a number of in vitro studies, and to add to those, I wanted to present this study here, which demonstrated that mesothelioma cells are highly sensitive to tumor treating fields. This study particularly assessed whether different tumor cell lines have different responses to tumor treating fields in vitro after 72 hours of treatment. As you can see here, glioblastoma cells are grafted, and you know the clinical data that we just discussed. As you can see here, cell viability as well as cell clonogenicity were substantially reduced in mesothelioma cell lines in particular, and more so than glioblastoma. For the chest, tumor treating fields are delivered using arrays of insulated transducers that are directly applied to the front, sides, or back. Now here you can see the layout of transducer arrays on a human anatomy model. These are laid out as cross arrays here, so that the front array on the right side is paired with the back array on the left side. Now overall, the field is strongest in the region between the arrays, and it diminishes in the regions not located between the arrays. It's important to note that the size and location of these arrays should be compatible with the size and anatomy of the individual patient. These come in two sizes, as you can see here. Now, to understand and calculate the tumor treating field's intensities in the human body, and specifically, we're moving on from what Dr. Ballo mentioned to the lung space, a modeling study was done using finite element mesh simulations of the distributions of tumor treating field's intensity. And as a reminder, tumor treating field's intensity is measured in volts per centimeter. This figure actually shows the distribution of fields in the lungs resulting from the cross array layout that we actually saw in the previous slide. And as we know from the in vitro studies, the efficacy of tumor treating fields increases with field intensity. As you can see here with this layout, a tumor treating field intensity of more than 1 volt per centimeter is achieved in the majority of both lungs. You can see that the electric field distribution is not uniform because of the differences in conductivity of various tissues, but we know that based on simulation studies, the distribution of the tumor treating fields is higher in the mesothelium than in the lung parenchyma. To move on to the clinical data, I would like to review now the STELLAR study. The STELLAR trial was a prospective phase 2 single-arm open-label non-randomized study evaluating tumor treating fields in combination with pemetrexed and either cisplatin or carboplatin in patients with previously untreated and unresectable malignant pleural mesothelioma. Patients were treated continuously at 150 kilohertz and targeted for at least 18 hours a day of treatment. They also received up to 6 cycles of their chemotherapy regimen. The primary endpoint of the study was overall survival, and secondary endpoints included survival at 1 and 2 years, radiological response rate, progression-free survival, and safety. Now here we can see the baseline characteristics of the patients who were enrolled into this study. The median age was 67 years, with a broad range from 27 to 78 years of age. The majority of patients were male and were not smokers at the time of study entry. The majority of patients, or 84%, had disease that was locally advanced. And with regards to tumor pathology, 66% of patients had epithelioid histology and 26% had sarcomatoid or biphasic histology. Now the median number of tumor treating field cycles was 8, with a range from 2 to 41. In this study, 1 cycle was 21 days, basically to mirror the chemotherapy regimens. That being said, the median number of chemotherapy cycles was 6, with a range from 1 to 7. The primary endpoint for this trial, the median overall survival, was 18.2 months. The 1-year survival rate was 62%, and the 2-year survival rate was 42%. Now I want to specifically note that this analysis provided evidence of benefit, but it does not provide the same level of evidence for efficacy as would a phase 3 randomized controlled trial that Dr. Ballo demonstrated in the glioblastoma section. Now historically, epithelioid tumors have better outcomes than non-epithelioid tumors, which was what was consistent with what we found in this trial as well. The median overall survival was 21.2 months for patients with epithelioid tumors versus 12.1 months for those who had non-epithelioid tumors. The median progression-free survival was 7.6 months, and similar to what we saw for median overall survival, the median progression-free survival was also longer in those who had epithelial histology at 8.3 months versus 6.5 months in those who did not have epithelial histology. Now, 72 patients in this trial had at least one follow-up CT scan performed to determine radiological response rate. Of these patients, 40% experienced a partial response, 57% had stable disease, and 3% of patients actually progressed to their first follow-up scan. This translated to a disease control rate consisting of stable disease plus partial response plus complete response of 97%. It's important to note that all patients who presented with a partial response experienced continuous reduction in the total sum of their tumors, and the median response duration in this patient population was 5.7 months. Now let's look at the adverse events. Now we see the incidence of grade 3 or higher adverse events that occurred in more than one patient in this study in this table. Specifically, there were no increases in systemic toxicity seen as a result of combining Tumor Treating Fields with chemotherapy, and no serious adverse events were reported to be related to the treatment itself. As we've mentioned in the first practicum, the only adverse event attributed to the use of Tumor Treating Fields was the expected skin irritation underneath the transducer right. It was grade 1 or grade 2 in a majority of patients in this study, and only 5% of patients had a grade 3 skin irritation, which led to temporary or permanent interruption of treatment. As we've discussed previously, most of these skin irritations actually resolve after treatment with topical corticosteroids or a short treatment break, and this was also observed in this trial. Now, in summary, this trial was the basis for the FDA approval of this device in this patient population. It was actually the first FDA-approved treatment for malignant pleural mesothelioma in over 15 years. At our facility, we reviewed this data and as a group decided to implement this as an option for patients with unresectable disease who are receiving this doublet regimen. Now moving on to emerging modality combinations in non-small cell lung cancer. Unlike mesothelioma, lung cancer is very common. It's actually the second most common cancer diagnosed in males as well as females, and the most common cause of cancer death. Now, non-small cell lung cancer accounts for the majority of cases of all lung cancers, and about 50% of patients actually present with advanced stage 3 or stage 4 disease. The average survival for patients who have metastatic disease with standard of care therapies was about a year, but immune checkpoint inhibitor introduction into this space has allowed us to extend survival, but that's still limited at close to about 2 years. Therefore, the search for effective therapies continues, given the common nature of this cancer and the need to develop additional effective therapies in this space. As we think about the different therapies that are available, we have chemotherapy on one side, immunotherapy on the other side, and then localized treatments, surgery, radiation therapy, and potentially tumor treating fields as well in this space. Now, we do have some clinical data supporting the use of tumor treating fields in patients with non-small cell lung cancer. Depicted here is a single-arm pilot study, a phase 1, phase 2, in 42 inoperable stage 3B and stage 4 non-small cell lung cancer patients who experienced tumor progression after at least one line of prior chemotherapy. These patients received pemetrexed every 3 weeks with continuous daily tumor treating fields applied to the chest and upper abdomen until disease progression. The primary endpoint for this trial was actually time to in-field progression, and it was observed in this study at 28 weeks compared to a historical control of only 12 weeks with this regimen. Importantly, the median overall survival was 13.8 months in this trial compared to the historical control of just over 8 months. The 1-year survival rate was 57%, and again, that's compared to a historical control of only 30%. This led to the ongoing LUNAR study, which is a randomized open-label study of tumor treating fields concurrent with standard of care therapies for the treatment of stage 4 non-small cell lung cancer following platinum failure. Patients are stratified by their selected standard therapy, either immune checkpoint inhibitor, docetaxel, their histology, squamous or non-squamous, and the region of the world in which they accrued to this trial. The primary endpoint is overall survival, and this trial attempts to accrue 534 patients. We have to put this trial into consideration with a number of other novel multimodalities in lung cancer, and that includes stereotactic radiation and immunotherapy, combination of chemotherapy, immunotherapy, and additional targeted therapies, potential for targeted therapy following chemotherapy and radiation, and the consideration of tumor treating fields therapy with immunotherapy. Now moving on to the second practicum. This is a patient of mine, an 84-year-old with malignant pleural mesothelioma that was medically inoperable and unresectable. As you can see here on the sequential coronal slices of his PET CT scan, his disease is predominant in the left hemithorax. He was started on chemotherapy along with tumor treating fields therapy, and he started off at about a 57% compliance. He did experience expected skin irritation with this, but after 2 cycles of chemotherapy, given his age and comorbidities, he had a decline in his performance status, cytopenias, and that resulted in a similar decline in his adherence to Tumor Treating Fields to about 32%. Once the chemotherapy ended, once we were able to manage his skin irritation, he did express preference to continue wearing the device and then increased it beyond this level. He completed his 4 cycles of chemotherapy along with concurrent Tumor Treating Fields therapy during the entire course and in the maintenance phase. As you can see here, his pre-treatment image CT scan as well as his post-treatment axial CT slice shows a partial response to treatment with reduction in the pleural component of his disease. A second CT scan about midway through the lung actually shows a reduction in that nodular component along the mediastinal pleura. This second case is a patient with stage 4 metastatic non-small cell lung cancer. She experienced progression of her disease after first-line triple therapy, which is chemoimmunotherapy, and as you can see here, she had predominantly lung disease with absence of other brain metastasis or significant other visceral metastatic disease. She has significant lung disease, as you can see here, in the right hilum, even encasing the right mainstem bronchus. Now, based on the most current NCCN guidelines for these patients, following platinum failure with or without the addition of immunotherapy, patients may be candidates for either immune checkpoint inhibitor therapy alone or single-agent cytotoxic chemotherapy. For patients who have significant pulmonary burden of disease, we do consider enrollment in this study as it is accruing at our institution. In fact, this patient was approached with this study, enrolled onto the study, and actually randomized to receive the Tumor Treating Fields therapy, which she has started since. Now, as we integrate these new modalities into clinical practice, this is a device, and Tumor Treating Fields are not a medication, and therefore there is extra training which is required. For this, device support specialists are able to assist patients in their home, provide an initial visit, discuss the use of the equipment, help with array placement, and even provide some evaluation and management of skin care along with the physician team. They provide interval phone or even in-person support as needed. Now, Dr. Ballo, I just want to reach out to you to see, can you talk about how you integrate these new modalities and devices into your practice as well?
Absolutely, yes. And thank you very much for that review of the use of Tumor Treating Fields in patients with thoracic malignancies. We've really made an effort to and have really used Tumor Treating Fields as a way of bringing together our multidisciplinary team. I mean, just as you had kind of mentioned, we've decided as a group to make this our standard of care. So, the thoracic surgeon is talking about it, the medical oncologist is talking about it, and then I'm talking about it. So the patients really see it as an important component of their care. If they see that it's something that I care about, then I think they're more likely to accept it. So we definitely approach Tumor Treating Fields as a multidisciplinary group. That's made a big difference for us. Okay, it looks like I did get a couple more audience questions, and one of them has to do with the logistics of setting up Tumor Treating Fields in your clinic. Another is talking about how can you work with your multidisciplinary team to kind of work these new technologies into your clinic. And then another one of the questions talks about how do you educate your patients about the clinical trials? So the whole idea of, how do you bring Tumor Treating Fields into your multidisciplinary clinic, and how do you make sure that your patients have access to clinical trials? Dr. Babaker or Dr. Kotecha, any thoughts on those questions?
Well, I can take a stab at a couple of these. So the first about setting up the logistics for Tumor Treating Fields in the clinic. There are 2 steps, basically. First one is to get the certification as a healthcare provider to prescribe Tumor Treating Fields. The second is, and this is specific for mesothelioma, given that it was approved under a specific pathway by the FDA, is that one needs to have a local committee or IRB approval to actually treat patients with this device in the clinical setting. So that's specific for that. kind of touching on that is that when we see patients in clinic with newly diagnosed disease, whether it's something rare like mesothelioma or something like lung cancer, we do offer a range of clinical trials to our patients as a multidisciplinary group that specializes in thoracic malignancies, from medical oncology to surgical oncology, thoracic surgery, and us in radiation oncology. We believe that it's best, number one, to offer patients a clinical trial. Outside of a clinical trial, we have pathways, care paths that are developed at our institution to be able to treat patients. And for example, for mesothelioma, we have decided that for any newly diagnosed patient who's unresectable or metastatic and meets the criteria for this, we would treat them as our standard at our institution with doublet chemotherapy and with tumor treating field therapy as an option.
That was a great point, Dr. Kotecha and Dr. Ballo. I mean, one point I'm going to add is that from a clinical trials perspective, I think it's paramount when you meet with your patients to discuss, at least in my clinic, what I do is discuss standard of care therapy, but also clinical trials. And that's very important right now because we're seeing more drugs or immunotherapy, or even in the case of TTF, more results showing positive responses when combined with other treatment modalities. So I think I've developed it in my practice that I would discuss with them, my patients' clinical trials, standard of care, and have them make that decision. The second point that I think is also very important is that now that we're seeing treatment modalities involving multitude of specialties, that expands not only, for example, oncology only, but radiation oncology, surgery, and I think it's very important, and device specialists to work as a multidisciplinary team to work towards treating patients. Like, for example, we see sometimes mild toxicities in our clinical trials. So now we also involved yet a different specialty, which is dermatology. So when at the first sign that we see some dermatological toxicity in our patient, we work with our dermatologists who've developed a flow chart to address those toxicities. So it's very exciting to see the world of oncology right now to span across multiple specialties to treat patients.
Excellent points. Yeah, another thing I would add is that it's a good comparison between starting Tumor Treating Fields on your patients and discussing clinical trials with your patients, because both of them you are much more likely to be successful if you do it as a multidisciplinary team. If you have your surgeon, your medical oncologist, and your radiation oncologist all talking about clinical trials, patients will see that that's important. And if you have everybody talking about integrating Tumor Treating Fields into the treatment of their solid tumor, they will see that that's important. So I think it's an interesting sort of correlation between the two. Very interesting. Thank you very much. Okay, now we're going to go on to Seminar 3. Dr. Babaker, would you like to present?
Thank you very much, Dr. Ballo. It's an absolute pleasure to be here to discuss with you some of our experiences with TTF and other solid tumors, and also to be in the panel with yourself and Dr. Kotecha. And I'm very pleased to be invited by the committee to present some of the slides. So, in conjunction to what Dr. Ballo and Dr. Kotecha mentioned, it's, the world of drug, of treatment development in the world of oncology, from an oncological perspective, that I'm an oncologist, is moving at a very fast pace, which is very exciting. So, but despite these major discoveries, mortality still seems to be very high in specific some malignancies with high mortality. So there's still an unmet need in some malignancies. Traditional modalities in systemic therapy, such as surgery, radiation, chemo, and target therapy, immunotherapy, do have some associated adverse effects relative to some of the efficacy it does have. And the search for more efficacious treatment modality to fight this war against cancer, yet to have really low toxicity profile is an unmet need. So essentially, beginning, we're going to start with TTF and pancreatic cancer. To your left there's a preclinical study that studied the combination of TTF in combination with gemcitabine. And as you can see in this specific preclinical model, Combination of TTF with gemcitabine showed significant reduction in tumor volume relative to controls or gemcitabine alone. And that diagram also displays cancer cell death that's related to TTF affecting microtubule formation and hence cancer cell division, and also migration of some of the organelles towards the foro during mitosis and hence cancer cell death. To your right, in GI malignancies and specifically in pancreatic cancer, when you look at some of the in vitro studies, the 150 kilohertz actually showed reduction of the proliferation of the cancer cells. And again, the device uses 4 transducer arrays, and as you can see in that picture, a device specialist is helping placing those transducers arrays for patients. And usually when I do explain to patients, I tell them it's akin to wearing a belt around where the tumor is. The Panova 2 trial was a phase 2 trial conducted in Europe that studied TTF in combination with chemotherapy in patients with locally advanced pancreatic adenocarcinoma, but also patients with metastatic pancreatic cancer. And as you can see there, the eligibility criteria were patients with advanced pancreatic cancer, ECOG of 0 to 1, treatment naive, and they looked at 40 patients. The first cohort included TTF and gemcitabine, and the second cohort looked at the TTF with nab-paclitaxel and gemcitabine, and the primary endpoint was safety. Secondary endpoint including PFS, overall survival, 1-year survival, 6-month PFS, and overall response rate. The first graph there shows PFS for all patients. Those are locally advanced unresectable pancreatic cancer and patients with metastatic pancreatic cancer. And the second top graph actually shows overall survival. And as you can see over there, the median PFS was 12.7 months for all patients. And the PFS at 6 months was 65%. The median overall survival was not reached for all patients, and the 1-year survival was 72%. This is really a robust results in a cancer that has significant mortality relative to the previous data that was presented per FOLFIRINOX as published in England Journal of Medicine, or nab-paclitaxel and gemcitabine. The lower graph actually separates some of the data from locally advanced pancreatic adenocarcinoma and metastatic. And as you can see over there, the median overall PFS was not reached in locally advanced pancreatic cancer and was robust at 9.3 months in patients with metastatic disease. And you can see that the 6-month PFS rate was 87.5% in locally advanced pancreatic cancer. And metastatic, that was 50%. Overall survival, depicted there in the graph, was significant for, most importantly, locally advanced pancreatic cancer, but also metastatic disease. But given our previous historic data with LPAC, or locally advanced pancreatic cancer, this is some significant data, and hence this led to a phase 3 trial that we're going to discuss in the next slide. And if you want to look at the comparison, you can actually look at the comparison in this table comparing our historical results relative to the data from the Panova 2 trial. And you can see the median PFS of 12.7 compared to 5.5, median overall survival not reached, and 8.5 with our standard of care chemotherapy. This really demonstrated robust results that subsequently led to our Panova 3 trial, which is an ongoing trial currently, and we look forward to reviewing some of those results in the future. So the trial enrolled patients with locally advanced pancreatic adenocarcinoma that are not amenable to resection. Patients had an ECOG performance status of 0 to 2. The plan is to randomize 556 patients in a 1-to-1 randomization. Patients would receive TTF plus standard of care chemotherapy with nab-paclitaxel and gemcitabine versus standard of care gem and nab-paclitaxel. The primary endpoint is going to be overall survival. You have your secondary endpoints depicted there. I'm going to overemphasize the fact that we're seeing a lot of advances in our fight against cancer from different perspectives, either immunotherapy, targeted drugs, but most importantly also a role for interventional treatment, specifically in locally advanced pancreatic cancer. So the first example there is a clinical trial ongoing that's looking at a monoclonal antibody targeting the connective tissue in combination with nab-paclitaxel and gemcitabine. But most importantly, the trial afterward is actually a specific catheter that delivers chemotherapy to locally advanced pancreatic cancer. So it's a catheter that through it you can give high-dose gemcitabine to where the cancer is. So what about other tumors, such as ovarian cancer? This slide reveals some of the preferred and other recommended regimens in patients with ovarian cancer that are resistant to platinum therapy. And as you can see over there, there's a number of cytotoxic therapy. There are targeted therapies such as olaparib, rucaparib, niraparib, and bevacizumab. You see other recommended regimens. You see hormonal therapy such as aromatase inhibitor. And you also see immunotherapy in MSI high or DNA damage deficient solid tumors. And you also see a role for targeted therapy with the approval in entrectinib and larotrectinib and NTRK fusion solid tumors, and also hormonal therapy. But despite those treatment regimens, there's still an unmet need in patients with platinum-resistant ovarian cancer. The Innovate Trial was a phase 2 trial. It was conducted, demonstrated a maximum antiproliferative therapy in carcinoma cell lines. So a preclinical model that showed an effectiveness of TTF at 200 kilohertz in ovarian cancer cells showed efficacy, which led to the Innovate phase 2 trial, which was conducted in 31 patients. And the regimen included TTF with weekly paclitaxel. You can see the results of the Innovate trial. You have to your left progression-free survival and overall survival to your right. And you see that the median PFS was 8.9 with TTF and paclitaxel relative to 3.9 with paclitaxel alone. The median overall survival was not reached with TTF and paclitaxel and with 13.2 with paclitaxel alone. Again, these were robust results in a phase 2 trial in platinum-resistant ovarian cancer that led to this phase 3 trial, which includes patient progression on after platinum-based therapy. The plan is to accrue 540 patients, who will screen to one-to-one randomization to either TTF plus weekly paclitaxel versus weekly paclitaxel alone. And they will be followed by scans to evaluate for response. The primary endpoint is overall survival, and the secondary endpoints are PFS and overall response rate. We've been discussing some of the toxicities you see with this treatment, and we've kind of shown previously is that most of the toxicities you need to watch out for are mild dermatitis. And surely enough, this is an analysis that was published in the International Journal of Radiation Oncology in 2008 that looked at the EF15, the Panova, the Cellular Innovate trial that demonstrated in 50% of patients had dermatological toxicities, but most of these toxicity was only grade 1 to 2 dermatitis, with grade 3 dermatitis occurring in 6% of patients. And only 7% of patients had a grade 1 to pruritus. So I think, using this treatment modality to fight the different solid tumors that we've discussed, I think it's very important, at least from our experience, to keep a low threshold for skin toxicities. I work at the University of Arizona, and we're based in Tucson, Arizona. And as you can imagine, our climate is hot. So we've learned through our experience, through our patients enrolled in clinical trial, that you need to work as a multidisciplinary team with your research team and with your dermatologist, and keep a low threshold for managing dermatological toxicities right away. So for example, we highlight to our patients, you need to make sure that when you apply the transducer array, your skin needs to be dry, meaning there's no sweat over there. With the first sign of some rash, we need to overemphasize the compliance with switching the transducer array per protocol, at least of 2 centimeters, and applying antisteroidal treatment earlier on. What about other cancer, solid tumors? We've discussed about pancreatic cancer, ovarian cancer. What about gastric cancer and hepatocellular carcinoma? So based on AACLD guidance for treatment of HCC, you can see there for patients presenting with stage 0 stage 0 tumor, you can see there depicted a single lesion that's less than 5 centimeter. The option is, level of evidence 1, resection. The other options you can consider RFA and microwave ablation. However, in a stage A, where you're having multiple nodule tumor metastases within the right side of the liver, the options are depicted there, which include transplant, RFA, resection, microwave ablation, radioembolization, TACE or SBRT. Stage B, the option is TARE or or TACE for downsizing or liver transplantation. And when the disease is more advanced, such as in stage C, then there's option for a multitude of therapy that are depicted there. And if it's stage D, then you're thinking about transplant versus best supportive care. The phase 2 Panova trial studied the treatment of TTF with sorafenib for advanced HCC, and I have to add there that that trial is currently active but not recruiting. The plan is to study in 25 patients, and the plan is for patients to start TTF with daily sorafenib. And sorafenib is a TKI approved as a frontline therapy for patients with HCC and a Child-Pugh class A. Of note, there was a previous trial that was conducted in one institution, and it studied the intrabuccal administration of electromagnetic fields to shrink the tumor size. This was studied in 41 patients. Patients enrolled had the Child-Pugh class A or B disease. 4 patients had an objective response, and 14 patients had stable disease. You can see the median PFS was 4.4, and the median overall survival is 6.7 months. So this kind of steps, hints towards a potential role for this treatment in patients with HCC, and we look at some of the results that are going to come off the Panova 2 trial. Shifting the gear to another cancer is gastric cancer. To your left is a graph that studied TTF with FOLFOX in AGS, which is a gastric cancer cell line. And that graph kind of shows the addition of TTF to different monotherapy chemotherapy relative to TTF in combination with that specific chemotherapy. And you can see that there's a significant reduction in these cancer cell colonies with the combination of TTF and that chemotherapy, and in FOLFOX with TTF relative to FOLFOX alone. And those exciting results led to a phase 2 trial evaluating the safety and efficacy of TTF at 150 kilohertz with Zolox combination in gastric cancer. And you can see there that patients are going to be treated with Zolox and TTF with a cycle of every 3 weeks. CT scan and MRI scan is going to be conducted every 9 weeks for restaging and look at response and at subsequently survival follow-up. The plan is to have 28 patients with follow-up for 12 months, and it's designed to detect and investigator assess overall response rate per RECIST 1.1, and we're very optimistic and looking at the results that should come about in 2021. This is a busy slide looking at different treatment modality within the gynecological and gastrointestinal cancer space. I don't think we have time to run through each of this trial. However, it does highlight that there's exciting treatment modalities coming out within these tumors that look at the combination of immunotherapy such as PD-L1 inhibition, CTLA-4 inhibition, NK cell treatment, SBRT plus TACE, nivolumab, and Y90 microspheres, hypofractionated radiotherapy, followed by immunotherapy with durvalumab and tremelimumab. So we're very excited to look at some of the results that are going to come out from these trials. So I think from my discussion and my colleagues' discussion before me, I think it's very important to approach a patient's treatment via multidisciplinary, multimodality care treatment. We're seeing that there's a lot of overlap between not only oncology, but radiation oncology, surgery, and now devices that are finding different approval in different solid tumor. So it's going to be quintessential to have that discussion of how to approach a patient's treatment. And novel techniques and options, including TTF and combined modalities, may improve historical systemic therapy approaches as I presented, And we look forward to the prospective trials that are ongoing that are kind of that will highlight some of these results. And and it's very important to, I tell my patients, I look at the glass half full, and I always encourage my patients that there's hope in the fight against cancer. Thank you very much.
Excellent, excellent. Thank you very much, Dr. Babaker, for that review. I think everyone would pretty much agree that this is a real opportunity for our patients. It's a real opportunity for basic science research. It's an opportunity for clinical research. You see that Tumor Treating Fields is still in its infancy, but we're seeing activity in diseases that have otherwise been very difficult to treat. And I think that there's a lot to come in the future, as both Dr. Kotecha and Dr. Babaker have alluded to. I really want to thank Dr. Kotecha. I really want to thank Dr. Babaker for participating in this. I want to thank you very much for listening and watching. Thank you very much for joining us today.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GKC860.